Hi everyone. Welcome to the Common Sense Oncology Journal Club and webinar series. We've got an excellent talk tonight about prognostication. How long have I got? Before I introduce Anna and in more detail, my name is Deme Karikios. I'm a medical oncologist, Common Sense Oncology Foundation member, and I work in Nepean Hospital in Western Sydney, and I'm also associated with the University of Sydney. For those of you who are joining us for the first time for Common Sense Oncology, I'd like the opportunity to go through a little bit about Common Sense Oncology before Anna does her talk. And for those of you who are rejoining us, thanks again for coming along. This is the agenda for tonight. So a bit about Common Sense Oncology. We'll then go into Anna's talk, and then we'll have a Q&A. Probably the best thing for the Q&A would be to type your questions in the chat, and I'll direct them to Anna. Of course, you can turn your mic off and ask questions directly if you like, but it might just work a bit better if we type the questions in the chat. So Common Sense Oncology, for anyone who's joining us for the first time and doesn't know much about us, as you know, or many of you might know, our mission is to really ensure that cancer care focuses on outcomes that matter to patients. So really trying to design clinical trials, clinical research with patients at the forefront. I guess our vision is that patients having access to cancer treatments that provide meaningful improvements is the most important thing, and meaningful improvements in outcomes that matter to them, irrespective of where they live and or the health system which they access their care. So we have three pillars in Common Sense Oncology. The first one's evidence generation, so really ensuring clinical trials are designed well and report outcomes that matter to patients, really having their views and what matters to them at the forefront of our clinical trial design. Evidence interpretation is also very important. So how we, as clinicians who are helping patients make decisions, interpret the evidence, fostering that real critical thinking in the evidence we review. And lastly, and most importantly for tonight, because it falls into this pillar, is evidence communication. So really improving patient, public, and policymaker understanding of cancer treatment options. And part of that's discussing prognosis. So Common Sense Oncology, we'd love to have you involved. There's a QR code here that you can register, become a free member. There'll be a newsletter that gets sent out to you. You can access to all the general webinar series and also join our meetings online. Just to spruik our most recent paper. So this is available free. Again, the QR code there for you. Really important paper written by some of the most amazing people in Common Sense Oncology who've really been driving this initiative, but a paper on the principles of design, analysis, and reporting of phase 3 randomized clinical trials. So really a checklist of what we think is the most important parts of designing a phase 3 randomized trial for cancer medicines and treatments. Just a bit more on the webinar series. So these will be monthly sessions. This is our second one for the year. There'll be all sorts of topics, journal club style, looking at certain clinical trials, things like this. We will have a patient panel at some point this year and lots of special topics. Common Sense Oncology has a social media presence, so follow us on X and LinkedIn to see what's happening. And just so you know what's coming up soon, there'll be a few sessions, particularly the most exciting one is our third annual meeting. Will be available, some of the sessions will be available online, so join in for those. And in May, we're going to have a look at the SONIA trial and the policy and health system impacts of that. So without much further ado, let me introduce Dr. Anna Vasista. Her talk's entitled How Long Have I Got? Estimating and Communicating Survival Times in Patients with Advanced Cancer. Anna's a dear friend of mine. We've shared an office both doing our PhDs together and when she used to work in Nepean Hospital, but she's currently working at Westmead Hospital in Western Sydney, and she's also a senior clinical lecturer at the University of Sydney. So without further ado, Anna, thank you for this tonight and giving us this really important talk. As you'll hear, I use this in my practice. I've heard Anna give this sort of talk before and I've implemented it into my practice. Hopefully you'll see how you can use it in yours. Thanks, Anna.
Thanks, Demi, and thank you to the CSO team for inviting me to present this. I'm delighted to do it. I'm just going to share my screen. And in terms of this talk, I've divided up the talk into 5 different sections. The first one is just getting an understanding of what patients actually want to hear about their prognosis. And to keep it in context, this is all patients with advanced cancer. So metastatic cancer patient, that's the population I'll be speaking about the whole time. The second thing was, so firstly, what do patients want? Secondly, what do they understand about their prognosis? Thirdly, how do doctors estimate and communicate prognosis? And then hopefully I'll give you a framework that's easily applicable to your own practice, where we can, I'll speak about a simple method that we use for estimating survival times for patients with advanced cancer, and how, lastly, how accurate or how good are we as doctors or oncologists when we estimate survival time for our patients with advanced cancer. So starting off, a little bit about what's there in the evidence and in the literature about what do patients want to know about their prognosis. So as doctors, we get asked about this daily, and we know that it's a really challenging conversation, and it's challenging for both doctors and patients. But we do know from the literature, and there is a caveat that this is mostly from the Western world, that many patients with advanced cancer want detailed information about their prognosis. They want it early in the course of their illness, and they want it frequently, and they need it to be timely in keeping with treatment decision-making. So looking at the data in a couple of studies, an older study done over 20 years ago surveyed over 100 patients with advanced cancer. And at that time, most people wanted to know their average survival time, which is, I guess, the typical case, or the shortest survival time without treatment, the worst case scenario, or the longest survival time with treatment, otherwise known as the best case scenario. And a more recent study done by Dr. Belinda Kiley and group, there was a survey they conducted a survey of over 500 people with a cancer experience, and they asked them whether they wanted, how they perceived receiving survival information in the way of a median overall survival, or scenarios for survival, which was the worst case, best case, or typical scenarios for survival. And overwhelmingly, 90% preferred the three scenarios versus a point estimate, which is often what's reported in clinical trials. They also wanted detailed information, and we know that detailed prognostic information helps patients make good treatment decisions and helps them make realistic plans for the future. And the most important thing, and I think this is the thing we struggle with as doctors, and that is that there's little evidence of harm to emotional well-being, and that was reported in multiple studies, and I've listed a couple of them on this slide as well for further reference. So we worry about upsetting patients about their prognosis, but the evidence suggests otherwise. And so that's what patients want. What do patients understand about their prognosis? Many patients don't actually have an accurate understanding of their prognosis, and this has been reported time and time again in the literature, that patients often overestimate their expected survival time and also misunderstand the intent of treatment. So whether it's curative or palliative, or just the nuances behind their treatment intent is often misunderstood. So what do patients want versus what are they getting? Another study of over 500 patients with advanced cancer, and albeit that study was quite a while ago now, only 18% reported that their oncologist had disclosed prognosis, and over 70% actually had a desire to want more about this, so wanted this information. And in a local study of over 1,400 patients in an Australian survey, half reported that they received the information that they wanted. So it's slightly better than the 18%, but still 24% wanted more information than what they had received. So there is a bit of a gap there. And given that those studies were over 10 years ago, our group surveyed, sorry, I'll move on to that. So a few things. Why do doctors hesitate to discuss prognosis? And this is what the summary of the data from about 10 years ago showed, that the number one thing was difficulty estimating survival time, fear of getting the estimate wrong, fear of upsetting the patient, and fear of being unpopular with patients. So because this was a while ago, we had a look at more recent data, and we looked at, we surveyed over 200 medical oncologists and oncology trainees in Australia and New Zealand. And we aimed to determine the attitudes of medical oncologists towards discussing prognosis with patients with advanced cancer, to update that literature from about a decade ago. We got 206 responses and found that the median age was 40. It was equally male and female oncologists responding. 80% were consultants, 20% trainees. Most of us worked in the public sector, and we were seeing a median of about 4 new patients a week. And interestingly, half of those 4 new patients had incurable cancer. So we're seeing a lot of patients who do have incurable cancer on a day-to-day basis in our clinics. So we looked at frequency and timing of prognostic discussions, and we asked what triggers a conversation about prognosis with a patient. And close to 100% of medical oncologists reported that they disclose prognosis when a patient asks for this information. Over 90% said that when they're stopping treatment, and 70% said it's about when they think that survival time is less than 6 months. Now, given that patients want information quite early on in the piece, I think we could all, including me, do a lot better in this situation. And interestingly, less than half did it at the initial consultation, which is understandable as well. So what did we all talk about during our prognostic discussions? So 88% of oncologists disclose a diagnosis of incurable cancer to their patients all of the time. So that's a large number, and that's reassuring. And we asked oncologists in this column, when you give information, how do you prefer to provide it? And then if you were a patient and you were going to receive this information, how would you like to receive it? And the scenarios for survival was the most popular in the way of, in terms of preferring to provide that information in scenarios for survival, but also over 2/3 wanted to receive information in this way. Interestingly, only 2% wanted it in the way of a median survival, and about 20% wanted it in the way of units of time without numbers, so weeks to months. And no oncologist said that they would give no quantitative estimate. So I think everyone's providing some form of an estimate. And we compared this to a survey that was conducted by our same group, where we asked over 500 patients how they felt about receiving information in the way of 3 scenarios versus a median overall survival. And overwhelmingly, everyone thought that, close to 100% of patients thought it was helpful to receive it in the way of 3 scenarios versus a median overall survival. And very interestingly, they felt that it gave hope and didn't take away hope, and improved the understanding of survival time receiving these 3 scenarios versus a median overall survival. So in our study, there were some barriers that were highlighted in terms of what stops us as oncologists from discussing prognosis. And over half, 50% said that family requesting that prognosis not be discussed was a reason. Not knowing the expected survival time pressures in the clinic, fear of causing stress to the patient or the family, and also fear of getting it wrong. So they were the main barriers we found in our most recent study looking at this. So how do we do it? How do we estimate survival in our patients who we're seeing on a daily basis. So often as oncologists, we refer to data from relevant clinical trials when we're trying to get some guidance about prognosis and survival times. But unfortunately, these survival times in trials are often summarized as just 1 point estimate, which is the median overall survival. And we also know that over the last, especially 5 to 10 years, there has been so many changes in oncology treatment with so many novel therapeutic agents hitting our clinics. And this has changed the survival time and continues to change survival time for patients. It's quite a dynamic process where things are evolving very rapidly. And therefore, we felt an updated review and method for estimating survival time in these patients with advanced cancer is needed. So I'm hoping to illustrate how we do this using one of a trial, a project or a study that we did. And we looked at survival times for patients with HER2-positive metastatic breast cancer. And we looked at all the recent randomized trials in this space. We aimed to provide useful estimates of survival time for patients in this population who were starting HER2-targeted therapies. And previously, we had determined that simple rules of thumb could be applied to chemotherapy trials when estimating survival times, and whether these same simple rules could be used in targeted therapy. And especially if simple multiples of the median overall survival could accurately estimate these survival times in patients with HER2-positive metastatic breast cancer. So using the percentiles of an overall survival curve, you can see that the 90th percentile, which is in red here, looks at the 5 to 10% of patients who die the quickest, so the worst case scenario. And the 10th percentile, which are the longest living patients within this population, and that's the best case scenario. And then the typical scenario, which is defined by the 75th to the 25th centile, and using the median as our main center point. So we've previously shown in chemotherapy trials that multiplying the median by a quarter accurately estimated the worst case scenario, and multiplying it by 3 estimated the best case scenario. And the typical scenario was between a half and double the median overall survival. So we looked at multiple randomized controlled trials of HER2-targeted therapy published over 15 years from 2001 to 2015. And all studies needed to have a Kaplan-Meier curve, and we separated trials into first-line and subsequent line HER2 therapy. And we extracted from every curve each of these percentiles, and then we also estimated these scenarios using the simple multiples of the median. And the estimates were deemed accurate if they were between 2/3 and 1 1/3 of the actual number. So there were over 4,000 patients in over 15 trials. And we looked at the median overall survival. So looking at 15 first-line single agent HER2 therapy trials, we found that the median overall survival was 33 months. And looking at the Cleopatra trial, which was the only dual agent HER2 therapy trial, the median overall survival was 57 months. And in all subsequent line single agent HER2 trials, the median overall survival was 20 months. And now, when we look at the scenarios for survival in the first line setting, you can see that the median was 57. The worst case scenario was 15 months, and the lower typical was 27. So that was the multiplying that by a half. And similarly, the median overall survival, 33 months in single agent HER2 treatment, and a worst case scenario of 9 months, a best case scenario not evaluable because the follow-up had finished at the median overall survival, and follow-up duration for a lot of our trials, as we know, stop soon after or a little bit after the median overall survival is reached. But overall, the scenarios for survival were as we had predicted. So, and similarly for the subsequent line trials in the HER2 single agent HER2 targeted therapies. So we found that using these estimates, close to 80 to 100% of the time, that was accurate when we were looking at whether these multiples of the median actually work. So that's very reassuring that even in the targeted therapy space, that these scenarios for survival and this simple method of estimating survival is working. So conclusions from this study. This simple method may be useful in terms of they accurately estimated the scenarios of survival, but it may also be useful and be able to be translated to other targeted therapies. And of course, longer follow-up is required to determine the upper typical and best case scenario, which is likely to be triple the median overall survival or longer, given the exponential nature of the survival curve. So what can we tell our patients and what can we take away from this? So for a patient who's coming into your clinic who's starting first-line HER2 therapy for a metastatic breast cancer, prognosis can be estimated and explained as a median survival of 57 months, a possible worst-case scenario of 14 months, a typical scenario of 2.5 to 9.5 years, and a best-case scenario of potentially more than 14 years. And one of the ways we can deliver this is if we imagine 100 people in the same situation as yourself, then we would expect the 5 to 10 who did the worst would die within 14 months. The middle half would live for 2.5 to 9.5 years. And the 5 to 10 who did the best would could live longer than 14 years. And you might say that this is a very highly selected clinical trial population where, it doesn't really reflect the real world. And how can we extrapolate this to represent the patient population we are seeing in our clinics? And we looked at this in a very small study where we looked at survival and cardiac toxicity in patients with HER2-positive breast cancer treated with Herceptin in routine clinical practice. And surprisingly, so in these patients, we looked at the records of 126 patients in 3 Sydney hospitals, and they were starting trastuzumab as first-line treatment, so older data. However, in this population, the patients were older than the trial population, and most interestingly, 23% had brain metastases in this population compared to no one in the clinical trial space. And we looked at these scenarios for survival, and I've just put in a little excerpt from the paper, and you can see that the scenarios for survival are actually remarkably similar, not too different from the clinical trial population. So it is reassuring that while we might have to down adjust a few numbers or depending on the patients who are sitting in front of us, generally speaking, this simple method is applicable in the real world setting as well. Another study that was done by Dr. Parsonson and our group looking at survival times for patients starting endocrine therapy. And we know that in this setting, ER-positive metastatic breast cancer, there's been a massive development in the way of CDK inhibitors. And again, when we looked at first-line CDK inhibitor treatment with endocrine therapy in close to 1,000 patients, this multiples of the median works, with the median being around 60 months, and then the worst case scenario being 17 months, and about half of that, so 35 months in that lower typical. Again, follow-up we're not quite there yet. There's limited follow-up, so it's difficult to comment on the upper typical and best case scenarios, but the curves are certainly following the same exponential shape, and therefore we can predict that this same method would be applicable in that situation as well. A common question we get asked a lot is looking at survival for patients with metastatic melanoma who are receiving immunotherapies and targeted therapies. And we looked into this in this particular population using the same method and found, interestingly, that in patients receiving targeted therapy for melanomas, for the treatment of melanoma, this method certainly works. The method of using the simple multiples of the median, but in immunotherapy trials where the curves look completely different, this method doesn't quite hold, and we need a different way of explaining prognosis in those patients. Is it because the follow-up is shorter, or is it because biologically the cancers are different, or the treatment, the biology of the treatment and the way patients are responding to treatment is different? That is something that needs to be explored further. So the last few slides of my talk, so we've looked at how do we estimate survival using clinical trials, what do patients want to know, and also what do they know and what's the gap. Finally, I just wanted to touch on how good are we as oncologists at predicting survival in patients with advanced cancer. And one of the studies we looked at was looking at the accuracy and prognostic significance of oncologists' estimates and scenarios for survival in advanced gastric cancer. So changing tumor streams a little bit, but we wanted to see how accurate oncologists' estimates of survival are and whether these estimates are independently predictive of survival. And we just use the INTEGRATE trial as a trial population and did a sub-study as part of this trial. So a refresher in terms of the INTEGRATE trial, that was a phase 2 randomized controlled trial where 66 oncologists in 53 centers internationally enrolled 152 patients to either receive regorafenib or placebo, so an older study. And then we separately had a prognostication sub-study and asked 66 oncologists to estimate the survival for 152 patients. And we thought the estimate was, we deemed it to be accurate if it was, again, within 2/3 and 1 1/3 of the actual survival. So oncologist estimates were not very accurate. We were accurate 29% of the time. So these are just point estimates of survival, and we got it wrong 2/3 of the time. And they were inaccurate. However, if we so the scenarios derived from the oncologist's estimates were remarkably accurate. So we found that 9% died within a quarter of the estimate, 57 lived half to double the estimate, and 12% lived longer than 3 times the estimate. And these results are very consistent with our model that we use to estimate survival time. So that's, again, very reassuring. So very quickly, the conclusion from this study was that point estimates were precise about 1/3 of the time. And if you use simple multiples of the oncologist's estimated survival time, we could accurately predict the 3 scenarios for survival. So what can we tell our patients? So when a patient with advanced cancer asks for the estimated survival time, we recommend estimating the median overall survival of a group of similar people and using simple multiples of this median overall survival to calculate the scenarios for survival. So if you thought a patient's survival time was 6 months, oncologists can explain that 5 to 10% would die within 1.5 months, 50% would live 3 to 12 months, and 5 to 10% will live longer than 18 months. And we know that providing one single number is not really very meaningful or very accurate. And we also know that scenarios for survival are accurate, and that's what patients want to hear as well. So overall conclusions as I wrap up, we know that patients with advanced cancer want detailed information about their prognosis, and that doctors find it difficult to estimate it for multiple reasons. And survival data from clinical trials is often summarized by a single point estimate, and that's not really that meaningful. And that we know that when we make a point estimate, it's going to be wrong 2/3 of the time anyway. And we know that this method provides oncologists with a framework for estimating and communicating survival times to patients with advanced cancer. One of the things that could stem from all of this research is the development of an online tool, which could be useful, which summarizes survival information for multiple different cancers and therapies. And I know that's a massive undertaking, and in this current era of so many new novel therapeutics, but having an online tool was something that was floated as a helpful tool that could be used in oncologist clinics, just like we use tools for clinical trials as well as therapeutics. So that's something that, something that could be developed in this space as well. And I guess acknowledgements, definitely this is largely the work of Professor Martin Stockler and Dr. Belinda Kiley, and I had the privilege of working with them. And also a thank you to all the other co-authors who helped publish all the other papers. So Dr. Megan Smith-Uffen, Dr. Andrew Parsonson, and Dr. John Park, who helped out with all the other trials that I've presented today, all the patients and doctors who took part in our studies, and the NHMRC Clinical Trial Centre and the University of Sydney. I'm happy to take any questions.
Thank you, Anna. Thank you for that fantastic talk as always. There's at least one question online, but I might just start, Anna, with a practical question. You mentioned patients. It sounds like patients want to hear about the best, typical, and worst case scenarios, but do you come across situations in clinic where patients say, I just want an average, or I just want the best case scenario? And how do you handle that? Do you try and get them to hear it all, or do you just go with what their preferences are?
Yeah, look, I think that's a really good question. And the thing to say about all of this is what studies and data has shown, and it doesn't take into account the individual needs of the patient that's sitting in front of you. And I think there's a lot of things, their cultural background, education, as well as socioeconomic things that come into play when patients actually want to know their prognosis or not, or want prognostic information. I think asking them what they know is a very good first starting point. And generally, I don't have a discussion about prognosis at the very initial consultation, because it's more about what are the steps we're taking just at this moment to help you. And usually it's a dynamic process that evolves, I think, over a period of a few consultations. And also, one of the things that I'm not sure if I presented it, or I probably didn't, it was patients always wanted to be asked before going ahead and giving this prognostic information about what would you like to know, and are you ready to have this conversation at the moment. And I usually try to do it with family or support people present. And often, sometimes we do have people coming in solo into their clinics. So sometimes I offer to have a second appointment with family members to further discuss this.
Yeah, great. I'll just remind everyone, please feel free to put your questions in the chat. If you do want to shout out and talk, just put your hand up and we'll feel free to shout out your question too. Vijay was just asking, Vijay Venkatesh, Anna, from the data you presented, it sounds like most of the population you presented were from hospitals in Australia, I guess including the clinical trial data. And roughly what was their socioeconomic status? Because I guess that has relevance to the...
Yeah, look, I think the real world data was taken, interestingly, from a Western Sydney population, which is this rich cultural mix of Sydney, We didn't record specifically the racial background, but we do know that they came from 3 different hospitals where it's considered one of the most racially diverse and socioeconomically diverse populations. So in Sydney, I guess people who live in Australia would recognize that there are certain areas within, or people who live in Sydney will recognize that certain areas within Sydney are more racially diverse. And I can't comment exactly on the racial diversity, but this would probably be the most diverse population compared to other parts of Sydney. And again, it's small numbers. It was 126 patients.
PG online, feel free to comment further if you want to ask more questions, but quite a socioeconomically diverse, I think, population too, Anna, which is,
Yes.
we're a wealthy country, but I think the population you surveyed is quite diverse, interestingly.
Yes. Yeah.
While I think about some of the other questions online, one of the things that you sort of mentioned was in patients, say with melanoma, where we do seem to see tails to the curve or flattening of the curves. This method might struggle a bit to estimate, I guess, the best case scenario.
Yes.
Again, I know it might be hard because you're not a melanoma doctor, but the language I get from melanoma doctors is that they might start to use the words not just how long you live, but cured.
Yes.
I don't know, it's a tough question to answer, but how do you deal with that? Or if you can see trials where you have these more prolonged flattening survival curves, how do you address that, or how do you discuss that?
Yeah, that's a really interesting question that unfortunately I don't think I have a really good answer to. When we looked at it in the paper, it was very obvious that the BRAF and MEK inhibitor trials followed that beautiful exponential shape, and the multiples of the median worked really well, even within a very, there were so many different first line, second line, subsequent line trials as the melanoma landscape kept changing. And it was the immunotherapy trials, we struggled to come up with a uniform way of explaining prognosis that wasn't just, oh, your chance of getting through this at 1 year was X, or 5-year survival. And I think cure is a tricky word in the metastatic population, and I'm not entirely sure how I feel about that, knowing that the follow-up is still, I mean, there is many years of follow-up, I know, but I think the purists amongst us will say, I don't know if you can use the word cure yet. And I'm pretty much going to be shot down by the melanoma doctors, I'm sure, online, if there are any. But yeah, certainly I would struggle to use the word cure, but we know that the immunotherapy, it's just a different thing. We weren't able to form any sort of framework for that.
Yeah, sure. And a Pujra palliative medicine resident from Delhi has a question, and you might know the answer, but they wondered whether you had any experience using a tool called the PIPS-B tool for prognosticating advanced cancer, if you've heard of that.
Oh, I'm really sorry. No, I haven't. I haven't, and I'm
Haven't
sure
either.
the palliative care doctors won't be too impressed with me being the fact that I did a PhD in this. But no, I'm sorry. And if Pooja wanted to elaborate more, I'm sure we could benefit from.
We'll have to look it up afterwards.
Yeah.
Sharada was just noting that many Indian patients opt out of discussing prognosis in the initial setting. I guess, not to stereotype, but are there particular groups of people you notice who really don't want to ever discuss prognosis, just never want to hear that stuff, and how again, how do you deal with that?
Yeah. So I think in my practice in Western Sydney, and it's certainly not, I know we're in the Western part of the world, and I don't want to generalize at all, and forgive me if this is a bit of a generalization, but I do find that in my subpopulation of Southeast Asian community, like patient community, I feel like a lot of the time, if it's the patient coming in with their family, that situation where the family's requesting that further prognosis not be discussed seems to be more of a obvious, that's the thing that I encounter more than the patient themselves saying, look, I don't want to know. It's often family members. And I know that's a generalization and it's in just the people I've been seeing in clinic, but there is quite a big cultural difference between the Anglo-Saxon community where it's the conversation is quite different.
Yeah. In my experience, I've often found that the family wants to protect the patient, and often the patient wants to know, or they already have a really good sense of what their prognosis is.
Yeah.
It's tough
That's
to
my
navigate.
sense too. Often patients know, they know when things are not quite right or not going well.
Yeah. Some wonderful comments online, and it's really I'm going to try and synthesize them because there's a couple of things there that I was asking and ask as well. Leslie Fallowfield mentioned that, how can you truly give consent to treatment when you don't know what your prognosis is without it? And I think a lot of people would agree with that. And in that sense, Anna, Richard Kelly asking a question which I was going to ask, which is, and I think Richard and I probably talked about this, so that's probably why he's asking it. But have you thought about, and a difficult question to answer, I'm sorry, but have you thought about how the 3 scenarios approach could be applied to the benefits of palliative treatments?
Yes.
When I'm in clinic, I talk about, you might get a few extra months or that might not work at all, but it's really hard to put that in more concrete numbers, I think, for people in that typical best and worst case scenario setting. Do you think this could be applied to that?
Yeah, look, I think definitely we wouldn't, I think that would be the gold standard, because I think patients want to know, well, what if I don't have any of this toxic treatment? What will my benefit be without any treatment at all? And some of the older studies that we looked at, that was one of the main things that patients wanted to know. Worst case scenario without treatment, or best case scenario without treatment versus with treatment. And I think we are just so we're so far removed from the whole concept of no treatment, especially in the first line setting or the second line setting. And especially if I'm treating breast cancer as my main tumor type, I think that's something that we grapple with when survival can be, many, many months to years. But I think that would be the gold standard, and how you could implement that into a model and how to present that would be, an excellent next step.
You raised a good point, actually, didn't you? Like, it's hard now for diseases like breast cancer, particularly where no trials are comparing first line to placebo anymore. So you don't have a good sense of modern prognosis, perhaps, without treatment. So it can be quite a challenging discussion, can't it? Because you don't have good data to translate to that patient about what would happen if you do nothing. There's none of the clinical trials.
And also not knowing the concept of no treatment in the setting of lots of novel therapeutic agents, where the catch cry is minimal toxicity and maximum gain, and that kind of situation where we're aiming for that ideal situation with our patients. I think the concept of no treatment is something that we should definitely think about, but often do not. I think, and that's driven largely by maybe what tumor types you treat and the amount of treatment therapeutics that we're so privileged to have in our country.
Again, tricky question, I'm sorry, but it was interesting to see the data that you showed that demonstrated that in a real world setting, although a very small data set, that the numbers were similar to the clinical trials. Often we get taught things don't, like the data from clinical trials are the best, optimal situation. And in the real world, you never really see as big a benefit as you're going to see from the clinical trials. When you're talking to patients and whether it's prognosis or treatment benefit for that matter, do you have a rough rule of thumb about how you adjust down benefits sometimes?
Yeah, so looking at, I didn't quite go into that. I probably should have. was when you look at a clinical trial and we look at all the, so with our meta-analyses for all these trials, we did a multivariate analysis that looked at what are the factors that affected prognosis. So for example, in this breast cancer study, liver hepatic burden was something that you would dial those numbers down for. And certain other things like whether it's first line treatment, how heavily pre-treated they are, and also whether they, a lot of our treatments that we used to use in the metastatic space, we're now using in the adjuvant and neoadjuvant space. So that number might be lower in future years because we're using up all our good drugs early on in the piece in the neoadjuvant and adjuvant setting. So it's very, it's a complicated algorithm to put through your mind in terms of whether you put those numbers up or down. But what we found really interesting was that 23% of those real world patients had brain mets. So usually we don't, see any brain metastases in clinical trial patients. And we found that certainly that those numbers still held true. I think it's a reflection of the patient, of the tumor. So HER2 positive breast cancer in a lot of patients is very, very, very treatable, and trastuzumab is a very good drug. So I think in that real world study, I think there's a few things going on in there that you might not see in other, like say, small cell lung cancer or other, upper GI cancers and things like that.
Yeah, sure. A couple more questions before we finish, Anna, or even comments. So Leslie made another comment and asked you to reflect on it, and I think it's an interesting comment actually, that the closer a doctor is to a patient in terms of length of contact, and if they like them, they can often be more overly optimistic about prognosis potentially. So have you seen any data where how you relate to a patient or commonalities you share might change how you prognosticate?
Oh, it's so hard. I agree. It's really hard, and you're being very optimistic for that. You're optimistic for all your patients, but there are some patients who I completely agree with that comment.
Yeah.
No, it is difficult.
Yeah.
To be more objective, and I think it's part of the human condition where you are driven to think a certain way based on your emotions. So we can base everything on the data and the trials and all of that, but it comes down to the patient sitting in front of you and the kind of, as objective as you are, I think your relationship with the patient in some form subconsciously will come into your optimistic or not thought.
Yeah. And maybe one last question. It's from Alice Minhinik. Thinking about communication of prognosis outside of the patient clinical setting, are there examples of the three scenarios approach being used in health technology assessment discussions, like say, for example, PBAC in Australia?
That's a very interesting point. And, I can see how it could be applied in different settings outside the clinic, but not that I'm aware of.
Yeah, I might make a cheeky
You would
comment
know,
here.
Deme.
I imagine sometimes when industry is submitting things for health technology assessment, they will often model best case because that will increase value and allow them to potentially have a higher price being asked for to be for reimbursement. But anyway, that's just my own observation and comment. Anna, I think we've put you through enough. Thank you so much for answering all those questions. I'm sorry if I missed any on the chat. It's been wonderful to hear you talk about this, a really important and interesting topic. Definitely falls in within the common sense oncology field of communicating better with our patients. So again, really, really appreciate your time. And hopefully everyone online's found this of value. There'll be more webinars and journal clubs coming this year, so keep an eye out for those. Again, thank you very much, Anna.
Thank you. Thank you, Demi, and everyone at the CSO team. I was delighted to do this.